Thank you very much, Miklos, for your very nice talk. And let me introduce you, Jonas Rosendahl from Martin Luther University from Halle. Indeed, I've initially introduced him because Jonas is a very good, well-known pancreatologist and geneticist. And he's a good old friend of the Hungarian Pancreatic Study Group. We have several common projects with him. So that's why I'm very proud to call him on the floor. Please, Jonas, please talk about this next generation sequencing methodology and what we expect from it for the future.
Dear Andrea, dear Balázs, thank you very much for the very kind introduction. Dear Peter, Miklos, and team, it's really great to see your ongoing effort has been so successful and will also be successful in the next upcoming 10 years. So we will meet at 2X again and then see a lot more papers coming out from this effort. And I can only congratulate you that you made this possible. So after this, maybe a little bit negative talk about genetics in chronic pancreatitis, I will try to address the question whether we can still find novel associations in chronic pancreatitis. And it might come out in the end that it's not that easy as we would like it to be, but I think it is still possible. So this should be a motivation for all of us to keep on with the good work. So where did we start? We started with a good setting as we had several kindreds, pedigrees of families with inherited chronic pancreatitis. And the good thing was that in many of these families, there was an autosomal dominant inheritance pattern. This is the fifth kindred that was described in the literature by GWAS et al. You can see that it's quite obviously an autosomal dominant inheritance pattern here. And this implies that it should be, at least with the novel methodologies we have, quite easy to find the underlying genetic case in such a pedigree. And the other thing we had is that we evolved a quite good pathophysiological concept. We believe that it has something to do with the digestive enzyme cascade, proteases, antiproteases. And this was formulated long years ago. Maybe it's not completely true what Hans Chiari postulated in more than 100 years ago, but it helped us to look into these pathways. And this, then in the end, is a very successful story. And even if Miklos said, if you take a look at the hypothesis-driven approach and say, okay, this could be a candidate gene, you're most likely not successful. I think in chronic pancreatitis, compared to other diseases, we are quite successful, as you can see here. And the story started with David's publication in 1996, where he was the first one to describe the association in the cationic trypsinogen gene. And thereafter, the whole story went along. And I think we have a lot of good publications and knowledge gained here. And it took a while, and this is quite interesting, that we transferred this knowledge into in vivo models. And it will take maybe even longer to transfer it into clinical practice. We have not any mechanisms evolved so far that can be advanced in a clinical setting. So maybe that is the real task for the future, as we are, like in acute pancreatitis, just running behind the disease. We are just doing something symptomatic, but we are not doing anything proactive, at least not as good as we want to be so far. And I think the CPA1 model that is presented here is maybe one of the best models we have so far. And you've seen yesterday a lot of other models that are evolving and seem very good to investigate such questions in the future. And hopefully we can translate this somewhere into the clinical setting. So it seems that, like in this apple tree, all the low-hanging fruits have been picked. But in the end, there will be still other associations, but it's getting more and more difficult to find them. And I want to show you just briefly some thoughts about how we might proceed in the future to identify these novel associations that are more difficult to find. Coming back to hereditary chronic pancreatitis, where we started, we have this pedigree still. But as you can see here, when we take the prevalence data that we have, which are not the best, so these calculations are for sure not the complete truth, then you can see that the cases we have in that we can investigate novel genes are limited. So in Germany, if the prevalence is really 1 in 300,000, we have roughly 280 patients with hereditary chronic pancreatitis. And I guess we know the genetic background in them in around 50 to 80%. So there's not much left, but with novel methodologies in good families, we might find novel genetic associations. And it seems quite similar in other countries. So if we want to be successful here, I guess we have to really come together and do this in a concerted effort. What about non-alcoholic chronic pancreatitis? The same holds true. The cohorts we have are limited. Again, the prevalence data we have are not the best, maybe not too reliable. Let's assume it's 1 in 16,000 persons in Germany that has non-alcoholic chronic pancreatitis. So we would have in total roughly 5,500 cases in Germany. And I just want to highlight one point we have to think of. I'm not saying that it's true what is following now. I'm just saying that we maybe have to go back to our clinical data phenotyping to be sure that we really enrich our cohorts and have a clearer phenotype in them. If we assume, for example, that like we have roughly 2,000 patients in our cohort with non-alcoholic chronic pancreatitis, we can say that the missing heritability in these patients is around 40%. I guess this comes really close to what is the truth. So we have 800 cases left in that we don't know what the genetic background is, if there is any background. And then if you phenotype incorrect, what happens? I'm quite sure in every cohort that's collected, it's not that easy to have the perfect phenotype because it's also difficult. And maybe there are also different phenotypes like in IBD, in chronic pancreatitis, that it's not the same if you have an asymptomatic patient, 80 years old, with calcifications throughout the organ, and then a young patient with calcifications. Maybe these are different disease entities and cannot be investigated in the same cohort. So if you have 5% phenotype incorrectly, then this reduces the total cohort that you really have to find novel associations to 760. And this, of course, depending on your phenotyping, can really diminish your cohort substantially. And maybe this is something we have to do now as it becomes more and more complicated. We have to go back to the files of our cohorts where we don't know the genetic background and really pick out the ones where the phenotype is quite clear to enrich the cohort and therefore enable us to find the novel associations. But, and Miklos is always co-author or last author of these publications, there has been substantial new publications in the last year. So, you know, all pancreatic lipase is a novel pancreatitis gene, and it's quite interesting when we take a look at the odds ratios here and see how this segregates within the family. So there seems to be a real heart risk factor. It's quite rare, but it's a quite high risk factor in these families. But it also highlights what is the new finding, or the new findings will be, as you can see here. We will just find rare variants, single variants. In this case, we find 4 variants in 400 patients, and this is the highest number of one variant found in this cohort. So it is getting more and more difficult to really assess whether these variants in combination increase the risk of chronic pancreatitis. The good thing, on the other hand, is that these hard factors will not be found in controls, most likely. And we have large control data sets available freely, so you can look into, let's say, 60,000 controls in the internet and then see that these variants will not be found in any control. So this helps us a lot to identify these novel genes in chronic pancreatitis. Of course, if it is the case that these variants are rare, the functional studies become more and more important. And we need good functional studies as displayed here for the pancreatic lipase, which is degraded by PRSS1 more rapidly. And if we have less replication cohorts and less cohorts to investigate in the first instance, then these data will become more and more important to really convincingly show that there are novel associations in chronic pancreatitis. And here it is summarized. I don't know how this leads to chronic pancreatitis, but I hope Miklos will explain it later on. It's quite difficult to understand why this variant that leads PNLIP sensitive to protease degradation is contributing to the development of chronic pancreatitis. Another novel gene identified recently is TRPV6, and I think this is quite interesting. Now, calcium is on the floor, so we have a novel mechanism that is associated with the disease. And this started in the beginning with a family. And in this family, it seemed that one variant segregated with the disease, but it shows then in the end that it's not so easy to use this family and exome data, because the variant identified here in the end shows not to be associated with chronic pancreatitis. So it was just luck, as Miklos pointed out before, that with this approach, TRPV6 was identified. But interestingly, if you take a look at GWAS data, and David could do this also, then you would also see a signal in TRPV6. So it might also have been identified by genome-wide approach. So all of you know that by the mutations shown in this gene, calcium influx is disturbed, and thereby it seems that we have a novel mechanism that, due to the calcium dysregulation, contributes to the development of chronic pancreatitis in these patients. And as Miklos pointed out, it will be very interesting to see what on a functional level happens, and maybe we can have more data from the animal models available in this cohort. And here is one of the screening cohorts shown, and it just highlights how difficult then genetic data are to interpret, because there are so many variants that you find. And it will be quite difficult to pick out the right ones if there is an association, and you could maybe do it also other ways around if you don't have functional data. So we really have to sit down and think a lot about such data and have good functional studies to identify the missing heritability in our patients. As Miklos said, of course, it's not always working with our thinking and our thoughtfulness that we will identify new candidate genes, and there are other approaches to do so. And I just want to show you briefly two of these that might be used in the future. We have on the right side disease co-citation. I think this is not the best tool that you can use to identify new candidate genes. It's more if you have an idea and find associations in a gene, you can take a look at this tool to look whether it also identifies this gene that you are interested in as a novel pancreatitis gene. And what this tool easily does is it just uses networks, and you put in the terms pancreatitis, and then it searches throughout the publications available how often the gene of your interest is linked with the term pancreatitis. This, of course, is kind of a literature research that you will also do when you search for a new candidate gene, but this is quite fast and maybe helps you in some ways. And you can see that here also the CCK is listed on the first page. So this might be interesting. On the other side, we have global networks that can be used. And with these global networks, you can use protein-protein interactions, but you also need to include functional networks for the purpose of finding novel pancreatitis genes. And what you do is you take networks that are available, and then you put into these networks your known pancreatitis genes, and then the random effect model and random walk model walks through this, and I cannot explain how this is happening. This is quite difficult, and just looks how in this networks interactions between the known pancreatitis genes and other genes are made. And you can see in the network displayed here that there are different pathways where the model can walk through. And then it just realizes how often it passes the one or the other gene, and then ranks them up to a ranking which is the most probable involved gene in this case, in pancreatitis, putting in SPINK1, PRSS1, CTRC. And this might in the future help to identify novel pancreatitis genes, but also, and we have to be aware of this, might be not as good as the thoughtful, chosen, hypothesis-driven candidate genes that we have used so far. But I think we have to use such novel methodologies also in chronic pancreatitis, as it is becoming more and more complicated to find novel genes. So one last point, this is the first GWAS in non-alcoholic chronic pancreatitis patients that we have just submitted to pancreatology. It was done by Andreas Schmidt. You can see that in this cohort of 584 patients, you find no novel association. You find CTRC and SPINK1, but nothing else. This might be due to the fact that there are not too many common variants in non-alcoholic chronic pancreatitis, and due to the fact that the cohort's not large enough to really identify novel associations in this cohort of non-alcoholic patients. But what you can do with such GWAS cohorts, for example, to understand which of the variants are really the functional relevant variants and maybe identify thereby normal variants. This Bayesian colocalization analysis, also again a very difficult tool I cannot explain in detail, but you take basically the GWAS data sets from the NACP cohort, and in this case also from the ACP cohort. Then you use the GTEx data publicly available. Then you do this algorithm, which is complicated. And in the end, it helps you to, for example, see that in the CTRC locus, there are two variants found out by the system, which might be the functional relevant variants, and they lead to degrees of chymotrypsin C. So this is in line what we thought is the mechanism behind this. And very interestingly, in the Claudin-2 locus, where David first described this association, it seems that the 2022 variant is the functional relevant variant that leads to an increase of Claudin-2 in these cases. So maybe this will help us in such complex loci like Claudin-2, where we have really not the best clue on how this works on the functional level, to further initiate studies to investigate this gene in chronic pancreatitis. So one last slide, next generation sequencing, as Peter mentioned. Maybe this helps us. Yes, of course. You've seen GWAS data, so we put a lot of money in GWAS, and we found something compared to other groups or other diseases. We were again quite successful, also with odds ratios that are good. We are not talking about the diabetes field where you have odds ratios of 1.1, but it's also complicated. Of course, there's an advantage. You are hypothesis-free. You have a global approach. You look at the whole exome, whole genome, depending on what you do. But there are also disadvantages. It's expensive, for sure. Maybe it becomes cheaper in the future. And then you have a large bunch of data that are difficult to investigate. And it's not that you just go to your computational scientist and say, okay, I want in 2 weeks de novo associations, because this is not possible to program it like this. You have to focus on several things, for example, on the known genes that are also associated, and look in this region first. And then it is possible to find all the associations, but unfortunately, it's not as easy as we all hoped it would be. And Miklos completely correctly said, there are no publications. If you take a look at exome publications in diseases, there's not much to find. So it seems that this technology is difficult to handle. And let's see how successful we will be in chronic pancreatitis. But again, we've been successful all the time. Why not in this case too? So what do we need to do? As I mentioned in the beginning, I think we need to take a look at all our well-phenotyped families that we have. Of course, these should not have known genetic associations, maybe not in all pancreatitis genes, but in the ones that have a high odds ratio. And I think we have to combine our cohorts and phenotype them again, maybe, or collect them prospectively, so that we really have cohorts with a high probability of genetic associations. And then I'm sure we will be successful and we'll have at least 2 new papers in 10 years. Thank you very much.
Is there any questions from the floor, teacher?
Yeah, congratulations, Jonas. So my question is, as you said, last 10 years, next 10 years. If I look at where we can use in clinic this data, the next 10 years. If I look at backward, gene editing improved a lot the last 10 years. Now, when will this be able to see in pancreatology gene editing?
It comes back to the discussion of yesterday. To detect it early, then we will have to be really early to detect these cases, unless the hereditary cases where you might screen it. If it's possible, then of course it could happen. But I guess in the end, chronic pancreatitis is so rare. There's not much interest in any company to develop such drugs or edit something. I'm not too optimistic that this will happen in the next years.
You, Maisa?
Thank you. Great talk, Jonas.
Thanks.
I do have a couple of maybe clinical, but you can say they're research questions. So I have the mantra in my practice that I say there's nothing in pediatric pancreatitis that is idiopathic. So this is how I start my practice. And when my fellows present and they say, well, we did the targeted 10-gene next-generation sequencing, Sanger confirms the positive findings, purely the state-of-the-art testing, we found nothing, or you didn't find anything. And this is a patient with no other risk factors, like all the etiology workup is negative. Is this a case you would think those methodologies could work?
Yes, I think you have a probable chance to find something with exome sequencing, not too high. But let's see how whole genome sequencing is going to change the field. There must be some supply sites that are relevant, or duplications, something like this. I'm quite sure, but this will not explain everything. I think there will be.
Obviously, if it's a family and I can get the proband and the mom and the dad and you find it, that would be the best case.
Yeah, this is for sure the best case. If you have screened it and didn't find any association, then you have a high likelihood to identify novel associations, but it's not as easy as we hope. It's not for 100% sure that you identify the underlying variant if it's present.
Yeah. My second part of the question, why just do it in the non-alcoholic? Why not do it in the alcoholic as well?
The exome sequencing?
Yeah.
We could do this. I think it's not probable that we find hard mutations in this cohort. But maybe I'm not right at this point. And the other issue is if you would have the money, then it would be possible. But I think it's quite difficult to get funding for this.
There are a lot more colleagues than not in Germany.
Yeah, we have a lot.
So we're accepting that alcohol alone is a risk factor.
Yeah. We're doing nothing against it, but we're accepting it.
Thank you for your talk. I've got a little bit different perspective as usual.
That's good.
So we have seen the model, the progressive model, and what we have been looking for is very strong mutations that cause early pancreatic injury and drive a bunch of consequences. What's interesting is that as you look at patients with chronic pancreatitis, some of them have pain, others don't. Some of them have a lot of fibrosis, others don't. Some of them progress rapidly, others don't. Some have diabetes and others don't. We've been trying to understand that because what we can do is often anticipate and modify the later things. Two examples is that we did a study, a nested study looking at diabetes versus no diabetes, and found out that the diabetes common in type 2 diabetes are triple your risk of developing early diabetes in chronic pancreatitis. And so it's an important modifier. We also did a study where we looked at people with severe pain versus not severe pain, and found that in the loci that were associated with severe pain were mutations associated with major depression, general anxiety disorder, and PTSD, so that their pain signals were the same, but the pain experience was amplified by defects in the pathways that are associated with managing pain and the dopaminergic pathways and some other ones that are very interesting as well. And at DDW, I'll be presenting our pain GWAS, and there's some additional findings there that we'll find extremely fascinating. So I think the genetics is evolving where we've gotten the low-hanging apples. The ones on the higher branches are actually on branches of different phenotypes within the larger chronic pancreatitis, and they have implications for other diseases as well. The same way with hypertriglyceridemic pancreatitis. And so I think that although things have been pretty quiet on the publication front, they'll pick up again, and you'll find some really interesting things by taking a novel approach to some of the nuances.
I completely agree that you have to take a look at what we have, take a look at the phenotypes, and find out if it's all the same or not. And it's not, of course, it's not one chronic pancreatitis disease. It's different in the one to the other patient. And I think it really makes sense, of course, that anxiety loci also might be enriched in these patients.
The ones with more severe pain experience, and there's others that have terrible pancreatitis and they're fine. How can that be?
Hi, this is Suhail Hussain. Can I ask a question from the Zoom?
For sure.
Okay, great. well, the question, hi, sorry, my video's fluky right now. The question is just regarding two things. One is, in cancer, we often think about somatic mutations, right? And here we're focused only on genomic mutations in a benign disease like chronic pancreatitis. But now with availability of pancreas tissue from, for example, pancreatectomies and so on, I wonder whether there's any thought of looking for somatic mutations that are discordant from the genomic. That's number one. The second is David, for example, David Whitcomb had a paper about the UK Biobank. And David, I know you're in the audience, you might comment on it. I wonder whether you could use GWAS to look at a broader population besides chronic pancreatitis. So, and even besides acute pancreatitis, such as what Marcus has published on high lipase elevations. But now you've got a much more well-phenotyped group with genotypic information. Just wondering about both.
Yeah, completely correct. These data sets are available and you can do a lot of work with them. It's, I think, just a question of time and the computational resources that you need for such doing such things. And then, of course, there are a lot of, I wouldn't say low-hanging fruits, but possibilities to address a really important question, as you mentioned. Regarding the sequencing of the pancreatic tissue, I'm not aware of doing this in any group, but maybe somebody else will correct me. Let's see if this would make sense. What would you look like in this? Would you look for, I mean, so far they looked for KRAS or something like this.
Somatic PRSS1 mutation.
Yeah.
I think there was a report of somebody who had a somatic CFTR mutation with chronic pancreatitis within the pancreas, but their genomic DNA was normal.
Yeah. Okay, then it seems very interesting.
It could be paired. It could be it could be paired tissue and blood DNA.
Yeah.
Isolated.
Julia had a question.
So I was just wondering whether the abdominal complexity should also be packaged. Because right now we just looking at changes.
Yeah.
Probably about understanding the time. Sure, the different layer of complexity.
Completely agree. Epigenetics, again, cost intensive, but would be at least, I think, in a well-phenotyped cohort, good defined, where we have the genetic background, really sure that these are cases of non-alcoholic or whatever, chronic pancreatitis, and then we should do both. It's just a question of, we have to unite, I think.
But you have to remember that most of these genes are very poorly regulated. So this is digestive enzymes. We just make them and that's it. So there's no intricate regulatory pathways. So it's very different from cancer. So epigenetics is not probably the best target here, which is still a possibility, but I think it's much less likely than in other diseases, particularly cancer.
I was wondering that there are a lot of factors, non-genetic factors influencing epigenetics, like childhood, obesity, allergies, alcohol, smoking. And I mean, most of them are recognized as modifying factors in chronic pancreatitis. That was, well, at least the thoughts I was coming from, but I totally agree with Jonas that it's a tremendous effort, it's expensive, and the outcome isn't good.
Like everything we do.
Thank you, Jonas.
Thank you.